Good afternoon, good evening. Thank you so much for joining us for the weekly briefing on health emergencies across the continent, brought to you by Africa CDC. My name is Margaret, Edwin, the Director of Communications. I will be moderating this session. Today, we are joined by the head of the Incident Management Support Team based in DRC, Dr. Ngashi Ngongo, who is going to lead the session. And I will now hand it over to Dr. Ngashi to start the session. Over to you, Dr. Ngashi.
Thank you very much, Director. Good morning, good afternoon, everyone, depending on where you are right now. We are taking this press conference from the US, where the Director General is leading a mission of the Africa CDC leadership to meet with the new administration here in the US. He's sending his greetings. He couldn't really join because he's meeting with some of the senators. I think that's the reason why we are taking this press conference without him. But as you know, this is a very interesting moment for everyone. That is really reshaping global health, the global health architecture. But at the same time, very interesting moment also for the Mpox response because we are moving into the intensification phase. That will help us to really get the outbreak under control. And hopefully that in the coming months, we should be able to lift up the public health emergency. I think with that, very warm welcome. And Director, we can then go through our presentation of the day. Yes, I would like to just give you an update on the Mpox, but also other health emergencies that are happening on the continent. Next. First of all, some of the key updates, as I said, the DG and the senior leadership of Africa CDC are visiting Washington right now. That is to discuss with the new administration, I think, the future of the US-Africa CDC collaboration. We understand all the changes, but we also like to look at these changes as opportunities as well, I think, to shape the new agenda, especially in line with the new public health order that Africa CDC is committed to. Last week, the DG reported that he had missions to Europe, to Norway and Sweden. I think these missions are just to really garner the understanding and collaboration around a new vision of Africa CDC, how we like really to adjust and also adapt the public health agenda on the continent to make sure that we are fit, I think, for the very rapidly changing global landscape. Also, we like to also announce that there are 3 countries that have finally resumed the vaccination. I think that's Rwanda, Uganda, and CAR. And the 4th country, which is Sierra Leone, is launching also its vaccination today, which is really great news. We also report that Central African Republic, after 6 weeks that they have gone with no case, now they have reported a new case. That's a country that was already in control phase that has slided back. But on the Ebola front, I think we still remain with no case reported from Uganda since the last update we provided you. Next. Yeah, just wanted to show some dynamic of the Mpox Clade 1b, which really calls for global solidarity with what is happening right now in Africa and the efforts that we are working on. You see that there have been 36 countries globally that have reported Mpox Clade 1b, of which 13 were reported outside of Africa. This year alone in 2025, we have already 2 countries that have reported that, France and the United Arab Emirates. But most importantly, that the majority of these cases had history of travel to Africa. I think that's the reason why when we talk about global health security, what is happening in Africa now is critical to our effort to really ensure that global health security, meaning it is really extremely important for us to work together to extinguish the fire in Africa, because protecting Africa is also protecting the world. Next. Some of the context that you are already aware of, so that to see how everything that we are doing needs to be adapted to the context, and why the Director General is really traveling, on this time to make sure that we really mobilize the key partners to understand the direction we like to take the public health agenda on the continent. We have 30% of health expenditures in Africa come from external aid. In addition to that, we have out of pocket that also accounting for 40%. You see that in reality, our government are only contributing the remaining 30%. But then at the same time, we are seeing a sharp decline in official development aid for Africa. Between 2021 and 2025, we've dropped from 81 billion to 25 billion. And in addition to that, you've heard what is happening now, both in America, in Europe, and so on. At the same time, we've also observed during recent years that the debt servicing of Africa has been increasing. That means we are getting less in, we are getting more out. That is the reality of Africa now. And when you look at the commitment that our head of state made 20 years ago to really meet the Abuja target of 15% of the budget allocated to health, it's only 2 countries that have achieved that. And in addition, as you all know, that most of the medical countermeasures that are used in Africa are produced outside of the continent. That is on one side. On the other side, we've reported several times that we've seen an increase in the number of outbreaks on the continent. Just between 2022 and 2024, a 41% increase. That is coupled with the vulnerability of the health systems that are very weak, and also the insecurity, I think, that is growing on the continent. All those factors will have serious consequences on the African public health agenda. We really risk the reversal of the 2 decades of health achievement on the continent. We are also concerned about the risk of another African-made pandemic, which might happen, and also that all that would also translate into more crisis with the economic vulnerability that will push more Africans into poverty. That is the difficult environment in which we are operating now. Next. Now, because of that, Africa CDC has come up with the new strategy. I think that's what the DG is just moving around to make sure that we mobilize as much as possible support for this new strategy of Africa CDC. That for us to maintain the public health agenda on the continent and move toward that safer, healthier, and prosperous Africa that we all aim at, in line with Agenda 2063. There are 3 main strategies that Africa CDC is putting on the table. One is that we need now to really work with the leadership to push the domestic financing agenda. You all heard, we reported to you back about the meeting that we convened around the AU Assembly in February with President Kagame, that was attended by our head of state. And then, in addition to pushing the domestic financing agenda, we are also thinking about innovative financing. Different mechanisms that we are considering, whether it's a solidarity levy on airline tickets or some earmarked taxes that could be sin taxes, on alcohol, on tobacco. But the AU itself had already committed also to impose a minimum import levy on goods that are imported into Africa. We are thinking about also the health insurance, the diaspora contributions. I think different ideas that we have put on the table on innovative financing. We are also looking at the blended financing. How do we also bring the private sector to invest on some of the key initiatives of Africa CDC around the local manufacturing, around the digitalization, connectivity, and solarization of our primary healthcare facilities, and also around the supply chain infrastructure. I think those are the three main strategies that we are now really putting forward. But in addition to that, all that is on the backbone of the optimization of the use of resources to ensure that there is less corruption, there's less misuse. We have the Lusaka agenda that is already mobilizing the global health initiatives to align, with national priorities that Africa CDC is playing a very important role. We have also the support we've provided to the countries on the efficient allocation, of resources. We have the African Food Procurement Mechanism. All those are different initiatives that we are also putting together to ensure that we optimize the use of limited resources that are coming to us. Next.
Apologies, Dr. Ngashi. Your video is a bit blurred. It might be the settings from your side.
Okay, perhaps is it not because of the... Let me just...
Okay.
Okay, perhaps it's because the slides are running.
From your side, I think. Yeah, we can see you now.
It's okay? All right.
Yes. Thank you.
Okay. Thank you very much. Okay, let's go back to the slide. Now, coming back to the Mpox situation in Africa, since the beginning of the outbreak to the week 11 in 2025, we've now reported 111,000 suspected cases, 25,900 confirmed cases, 1,724 deaths among the suspected cases, giving us a case fatality rate of 1.5%. Now, when we look at week 11 itself, we've reported 3,323 cases compared to 2,711 the week before. That means that we have a 22% increase. We've seen the same increase on the number of confirmed cases, 925 against 381, but some stabilization on the number of deaths, both on the confirmed and the suspected. But what we see is that the situation remains the same, that Uganda, Burundi, and DRC account for more than 90% of all confirmed cases. That's 91% in week 11. And we are also seeing that this data confirm the sustained community transmission, in these countries that are affected. But on the case fatality rate, we are seeing a decline. Remember, when we started the year, we started with a case fatality rate of 1.8, but now that is going down to 1.5%, meaning that it is done some improvement we have seen in the care seeking that is much earlier, and also in the quality of case management. I think that helping us improve on the case fatality rate. Next. In the DRC in particular, in total, 85,000 suspected cases since the beginning, 16,000, almost 17,000 confirmed cases, of which 1,675 deaths, coming to a case fatality rate of 2%. Now, during week 11, the new cases notified were 2,451 against 2,183 the week before. That's an increase of about 12%. The same trend on the confirmed cases, 312 against 150. That's almost doubling, I think, compared to the previous case. And also, the reporting coverage has really improved once again. from 19 provinces out of 26 that he reported the week before to 21 provinces in week 11. In DRC, we still have the co-circulation of clade 1A and 1B. And on the testing, I think we can report that there is an improvement on the testing coverage, which has moved from 13% the week before to 30% in week 11. Now, what we see is that there's an increase of suspected cases over the last 5 weeks. I think that is observed. And also the testing coverage that is also now starting to go up again after about 3 to 4 weeks of decline. Now it is good news that we see that reversing positively. Next. In Sierra Leone, also, we have, you remember that the outbreak in Sierra Leone was declared in January 2025. So far, they have reached 113 confirmed cases, I think 2.7 among pregnant women, and also slightly less than 1% among health workers. There have been 2 deaths, bringing the case fatality rate to 1.8%. But what's interesting that these 2 cases, all of them had some underlying conditions. On the admission, the case management, 63 cases have been recovered and discharged from the treatment centers, but there are still 48 that are active currently. On the contacts, there are 607 contacts that have been followed, of which 430 have already completed the 3 weeks of follow-up. Now, on the vaccines, I think we still have 8 countries that have received the vaccines, but there are 6 countries that are now vaccinating. You remember that we had 5 before. With Sierra Leone launching today, that makes 6 countries. We have so far 444,000 persons that have been vaccinated. And there are 2 countries, that's Uganda and Nigeria, that have received additional doses of vaccines, and the shipments that are being also arranged for 4 countries. That's Kenya, DRC, Uganda, and South Africa. Next. Now, in Sierra Leone, I think they've received 58,300 doses. And as we say, the vaccination starts today in western area, both urban and rural. And the target is the population 12 years and above. Unlike DRC that has already now gone down to 1 year, I think there's still work to be done in Sierra Leone to also move the target population much lower. But in addition to that, I think there are health workers that are targeted, contact sex workers, and other front line workers that are also part of the target of vaccination. Now, that's it on the Mpox response, but we also wanted to say that the incident management support team has now completed its second plan, which will be focusing on intensification of the current response in terms of scale and scope, but also the integration and the legacy, as we are also considering the exit strategy to ensure that we leave a resilient system behind that will be better prepared to face future outbreak than we were at the beginning of the Mpox. We maintain, I think, remains within the frame of the 4 ones, 1 team that is still collated by WHO and Africa CDC, 1 plan, 1 budget, and 1 M&E, with a number of partners, about 28 of them that are fully engaged and working together to help the African countries get control of the outbreak. Next. Now, the goal of this plan is 3-pronged. I think 1 is that in the countries that have presented outbreaks, it is to stop the human-to-human transmission. In the countries that are endemic, it is to reduce by half the burden of Mpox in those countries. And in all countries, it to ensure that the system is strengthened for resilience as part of the epidemic or pandemic preparedness and response in all countries that are concerned here. Now, the response strategy is mainly community-centered. I think there's a very strong component of the community package with under the leadership of the community health workers. It is a multi-sectoral approach, and also that it relies very much on strengthening the coordination at national and subnational level. And one dimension that is going to be amplified is the digitalization of surveillance to ensure both quality data but also transmitted in real time. It's also based on a syndromic approach with the realization that in a number of countries we've seen that the surveillance on Mpox has just helped also reveal other ongoing diseases like measles, like chickenpox. That the management with one that is integrated once in, I think they all benefit from the care, the diagnosis and the differential diagnosis, and then channeled through the appropriate care depending on the condition that they develop. The laboratory decentralization is one that was started already during the first phase to be accelerated. It is also part of the legacy that we want to leave behind, that it's much stronger diagnosis capacity at the end of the Mpox outbreak. Vaccination is being accelerated. I think we presented to you the data from DRC. You can see what we mean by acceleration. And finally, is the entire system that we also want to strengthen for resilience. Next. Now, the key targets on surveillance, as we are deploying now more community health workers to do active case search from house to house visit, we are expecting a sharp increase, about 50% in the number of cases. At the same time, also with the same community intensified follow-up by community health workers, we are also pushing the contact tracing with the target of having at least 20 contacts per every confirmed case. On the laboratory side, we are now around slightly over 50% testing coverage. We want to push that to 80%. And the genomic sequencing also, we are targeting 8% of confirmed cases that have to be sequenced to be able to track the mutations, I think, that are happening with the Mpox, as we just reported last time on the outbreak 3. On vaccination, I think the target is to cover at least 80% of the target group in every country, and we estimated that in total we need to vaccinate about 6.4 million people during the next 6 months of this second plan. And on the case management, we target at least 80% of confirmed cases that need to be taken care of, considering that at least 60% of those have to be in the health facilities. Next. Now, how does that translate into money? The total budget estimated is 429 million. I think that is about a third decrease from the 599 million that we budgeted for the first plan. And that the intensification will take about 80% of that budget. And then the legacy, which is the health system strengthening, will take about 20% of the budget. But also most important is that we have increased the funding for surveillance. That now takes about a quarter of the budget, and also vaccination and logistics that take another quarter. Those two pillars alone take about 50% of the entire budget of this second plan. Next. Now, what are the prospects of really mobilizing the funding? I think the key message is that we were able to get pledges around 1.1 billion during the first continental plan. But of that, with our online financial tracking, we're able to track only 977 million. But the most important that we've noticed that of the money that we are looking for 429, we still have 196 million that were pledged from the first plan. Just to say that in these pledges, it is all the other donors except the US, meaning that we understand that the US has made it clear that I think some of these commitments are no more going to be taken forward. And then that translates into the actual gap of 224 million, which is the new money that we need to mobilize to be able to close the gap. Next. Now, just also a word on the Sudan Ebola virus in Uganda, that this is now about 2 weeks since the last case was discharged. I think we are on the countdown that no more case that has been reported. I think, but the surveillance has been strengthened and continues there to make sure that there are no other cases that are missed in the follow-up. Next. In Angola, on the cholera, I think cases are still on the increase. During week 12, there were 1,133 cases against 842 in week 11. That's a 31% increase. Also, on the case fatality rate, now they are at 4.1%. There's also a 4% increase in deaths. And the two provinces that are newly reporting cases include Lunda Sul and Bié. In terms of the profile of the people that are affected, that 55% are males, and also that account also for 68% of deaths. And the age group below 15 years only account for 21%. And in total, there have been 8,543 cases, 329 deaths, with a case fatality rate of 3.8%. Now, 16 provinces in total that have been affected. In terms of the response in Angola, I think the vaccination is rolling out to the targeted groups, including the healthcare workers, as we reported last time. In addition to that, I think Africa CDC, we've deployed additional epidemiologists to go and support the country as the situation is still on the upward trend. At the same time, we are also supporting the country to finalize and also deploy the cholera case management guidelines. As you see that the case fatality rate is still very high, we really need to take it down. And all the partners are working together, including WHO, US CDC, and UNICEF, to just help the country get the situation under control. And finally, is there to say that the Mpox trend is still on the upward trajectory, with the continuous spillover of cases outside Africa, as we reported, France and the United Arab Emirates. I think that have been also that have reported cases in 2025. But we have a new plan. A new plan is focusing on intensifying the current response, but also think about the integration of some of the intervention into the existing systems, but also looking at the resilience, things like the laboratory that we really working on, the decentralization, the digitalization of surveillance, the rollout of the IPC to the community-based IPC with community health workers, and also the case management. I think there are strategies in each of these key areas that have been put in place to help that acceleration phase that we are engaging in. But our main challenge would be on the resources, both the funding and also the vaccines. As you've seen, we are really working very hard to mobilize additional resources, with same challenge also to work on mobilizing the $224 million that we need for the new plan. I think that's the reason why there is really that urgency of the resource mobilization that will also count on all of you really to support our effort in that direction. I think, Director, that is the essence of our presentation. I would like to thank everyone for your attention. And then we can open it up for comments and questions.
Thank you very much, Dr. Ngashi. Let's take the first two questions from the chat group. We have Gilbert, a freelance reporter from Kenya. He asks, with the US halting of funding to Gavi, how serious will this impact vaccine supply in Africa? And then we have the second question from Ida of Internews. The question is, how is Africa CDC affected by the recent cuts by the US government around the world? And even if not affected, can you please provide a short commentary on what Africa CDC is doing about this? Over to you, Dr. Ngashi.
Okay. Yeah, thank you very much, Director. On Gilbert's question about Gavi, we had a recent meeting with Gavi around about 3 to 4 days ago. I think the DG met with Sanya, the CEO of Gavi, just to discuss collaboration between Gavi and Africa CDC. I think we are in the US right now. I think the news came yesterday. We are gathering all the information. We know that Gavi is critical, really, for the delivery of vaccines in Africa. We know that. We are gathering all the information to understand also how far this decision goes. And once we have the information also with the different discussions that we have with the administration here, we'll be in a position to really understand how deep that would be. You know that the US contribute about 13% of Gavi resources. That's a lot. I think that's a lot, but we just need to get more information. I think we'll be in a position then to say exactly what should be the action moving forward. But there's no doubt that Africa CDC fully supports Gavi. That's the reason why we have this regular interaction with Gavi, because of the important contribution they're making both in routine vaccines, but also during the time of emergency. As you know, that they're making a huge contribution to the Mpox vaccination as well. Now, on the global financial situation, we say that it really doesn't help to complain, but we have to be proactive in terms of thinking that if that is the new normal, if that is the direction that the world is taking, how do we remain fit in that context? What are the adjustments that we also need to make on our side to turn this challenge into an opportunity for Africa? I think that's the angle that we have taken, that we really want to turn that into an opportunity for Africa. We've come up with the strategy I just shared. It is important at this time that we do increase domestic resources. Health is key to development. You cannot really leave your health in the hands of the partners, which is also true. That how do we then also ensure that with our own resources, if we can clean up our own inefficiencies, we can secure as much funding as possible. That's the reason why we are working with President Kagame, because Rwanda has got a very good experience in the area, that we can also have that kind of support and engagement from the other leaders to do that. It is critical. I think that's one thing. We didn't wait. As we know, we started already since February. We convened already the head of state, because we don't want to be victim. We really want to be proactive and lead the agenda. The second thing, you remember we had started this discussion about innovative financing 2 years ago. Now, with what is happening, it just helps us accelerate that discussion. It is critical that we find our own funding streams, I think, that are locally made, that are not dependent on the decision of partners, but that make kind of the contribution of the Africans themselves to advancing public health. That's the reason why this discussion about innovative financing is critical. Whether we'll agree on the airline tax levy or on the sin taxes, on health insurance, whatever, I think, but the discussion is quite advanced. It is important. But we also recognize that we can also take advantage of health to turn it into a business that also generates the income that we can then reinvest in public health. For example, we are thinking about the digitalization of health record. If we have an electronic digital card, that becomes then the basis for storing electronic medical record, but also some of the public health data like yellow card vaccination. We all pay for yellow card vaccination. All of us do pay for that. Now, if we could then make a contribution to that, that can generate resources that can then go back and save our outbreak management and then our health agenda. That's the reason why we are looking at it, that the local manufacturing agenda, which is that if we can then invite the private sector to come and invest in the local manufacturing. Medicines and other medical countermeasures, they also produce revenue. A part of that revenue can be also reinvested, in supporting some of these public health interventions. I think that's the way that Africa CDC is approaching this, is to come up with a new health financing strategy for the African continent. We started by really mobilizing, our leadership. As you remember, we started with the head of state. We convened that meeting that was attended by, about 46 ministers and deputy ministers, where we presented that strategy just to ensure that we have the buy-in. And now we are sharing the same with our partners in the West to ensure that all constituencies understand the Africa CDC approach now to addressing the health financing crisis with a strategic solution that everybody can also see how they can support us moving in that direction. That is what Africa CDC is doing.
Thank you, Dr. Ngashi. Let's cross over to the floor for the next question. We have Janice from Bloomberg. You have the floor.
Hi, thanks again. My question leads on from the first question asked. Just, in light of the fact that Africa CDC is in DC this week, and we've had this news about, cutting funding to the likes of Gavi. I was wondering if you've been able to bring up this massive concern. We keep hearing about how a health threat anywhere is a health threat everywhere. And just first question, just wondering if you've raised that concern specifically this week in DC. My second question was just leading on from that. If you are having to start to prioritize vaccines for the number of the various number of diseases that we are highly concerned about across this continent, where will you, what is most concerning to Africa CDC? Where is your priority on ensuring that vaccine supply remains in the unfortunate event that maybe some are having to be cut? And then the third one was just following on from what you were talking about now in terms of the private sector and vaccine manufacturing. I was just wondering if you could give any sense of whether you're seeing interest from the private sector, and if so, from where in the private sector? Is that local private sector on the African continent, or is that outside of the African continent? How much interest are you seeing? Thank you.
Thank you, Janice. I'll pass over to Dr. Ngashi for his response. Over to you.
Yes, thank you very much, Janice, for those very interesting questions. I think on the first question, where we've raised this issue in DC, the news came yesterday, but already we had a very large meeting with the three most important parts of the administration in one room. We had the White House Global Security and Diplomacy team there. We had HSS, we had the State Department, all of them in one room. We raised this issue and we made the point, which was also accepted by the American counterparts, that global health security starts with what happens outside the US. As you see that as much as they are concerned about global health security and the health security of America, we made a point clear that what happens in Africa also has got a bearing on that global security and the effort of the US government to ensure health security on the continent. That when you look at most of these major pandemic or outbreak that have been experienced in the past, whether it is COVID or now Mpox, they always come from outside the US and they land in the US. I think that message was very well understood, and we had the commitment that was clearly mentioned that they remain committed to addressing health security. They see the value of them supporting health security effort in Africa as a way of also protecting the American people. That message was passed, and there was no problem on that. There was consensus. I think where we need then to continue the discussion is that from the administration's perspective, is that they would like to see more of health as a business rather than something that functions on ground. I think they are exploring how can we go into a partnership that translates health as a business, which for us makes a lot of sense also, because things we want to do, like the local manufacturing agenda, it is a business. It's not, we're not pushing any grant. I think we have the African manufacturers that want the private sector or the banks to invest in them. They will do the tech transfer. They will beef up the infrastructure. They will produce, but they will be selling and then repaying back. I think that's that concept of the business really resonates. I think for some of the key things that we are doing, and then we spoke about the digitalization agenda. I think that's something that can also benefit from the private sector investment and the other areas that I was talking about, whether it is the electrification of the primary health care facilities and so on. That message was passed in general, and that is even the basis of the partnership that we are discussing, is even in the new format of health as investment, can we then get also the private sector coming to invest on the African continent, in partnership with Africa CDC. Now, that touches to your last point about the investment, the contact with the private sector. I think we started taking contact with private sector in Africa. All our key guys that you know very well, the big shots. I think we are in touch with them. But in addition to that, we've also started engaging also the private sector both in Europe and in America. We are really spreading our net wide enough because you don't know who will be finally interested to come and adventure with you. I think that's why we are not really restricting, especially except based on the values, if the values do not match ours. Now, on your last question about the vaccines, there's a list of vaccines that were prioritized, starting with some of them are the routine vaccines, like the pentavalent, now moving into the hexavalent. But some also are emergency vaccines, like the oral cholera vaccines and so on. I think there's a list that was already convened, but it really prioritizes to maintain first the current routine vaccination, with the vaccines that are needed, but at the same time looking at the frequent, emergency diseases and the vaccines that prioritize those diseases. Now, the good news is that within Africa CDC, we do the pathogen prioritization, to be able to identify what are the pathogens that are most likely to cause outbreaks. And I think those are the ones that we also prioritize for the production of the medical countermeasures. And the prioritization of vaccine is actually guided by that work as well. Over to you, Director.
Thank you very much. Let's take the next question from Kerry of Health Policy Watch. You have the floor.
Thank you, Margaret. Also following on from the similar questions, we heard. Could you tell us who exactly you have met, the names if possible, and whether you have priority programs that you are trying to get support for, and also whether you've got any indication about what is going to happen to PEPFAR, given that its reauthorization expired on Tuesday? Thank you.
Thank you. Let's take the next one before Dr. Ngashi comes in. We have Nkechi from BBC. You have the floor.
Okay. Can you hear me? Sorry.
Yes, we can hear you. Go ahead.
Okay. My question is, First off, there could be dire consequences for children in Africa following the US announcement on Gavi. Could the Africa CDC give us a sense of what is at stake and how prepared is the CDC for the fallout of the impact of this decision as regards disease outbreaks and the lack of access to vaccines for children on the continent?
Thank you. Over to you, Dr. Ngashi.
Yes, yeah, thank you very much to both Kerry and Kechi for these questions. I think Kerry, I don't know if I can give the exact names of the people. I really don't know, but what I can say that we had high-level representation from HSS, including the person who's coming now to head US CDC. I think they were all in the room. We had also high-level representation from the White House, from the global health security and diplomacy section. And then, as I said, we also had high-level representation from the State Department. I think that at least the people that we met, I think very senior people that we engaged with. And the meeting was at the State House. Very interesting meeting. It lasted, we started at 8. We went from 8 up to 1, just to tell you that it was a very long meeting, I think 4 or 5 hours. Very interesting discussions. Now, in terms of the programs, I think the discussions were turning around two things. One is on the health security agenda. And then on the second thing is the support for Africa CDC health financing strategy. See, those are the two things that we discussed. On the programs, we spoke about, let me also say that there was a representative also from PEFA, an assistant director, assistant secretary that also came from PEFA. Now, on the programs, we discussed about malaria, HIV, I think we're part of the discussions, and also the support in the area of systems for emergency preparedness and response, in particular surveillance, laboratory capacity strengthening, and also the health workforce. I think those are the areas that were considered. And then on the strategy itself, I think the main discussion was how do we support the agenda of innovative financing? How do we support the agenda of blended financing? What could be the role of the American private business? I think into that, and there were even discussion that they will facilitate some of the contact with some of the the private business in America that might be interested to work with Africa in those areas of local manufacturing, in the area of primary healthcare strengthening, digitalization, connectivity, and electrification on the other side. I think those are some of the specific things that we're discussing. Yeah, but the aim of us was not really to sign an agreement or something like that. We just wanted to make sure that we understand them. They also understand what are the priorities for Africa CDC. And then after that, then we can then continue the discussion, because the team will be coming back to the US in April for the spring meeting in Washington. That will be another opportunity to continue the discussion, if that can come then down to something that is specific. Now, on the PEFA thing, we did not speak particularly on what kind of support we can provide. But what we discussed is also on the other side, that if they went ahead and then, as it is already announced, what are the opportunities in what Africa CDC is doing now, or this new health financing agenda of Africa CDC, whether it is through domestic resources, whether it is through innovative financing or blended financing. How do we then leverage some of those resources also to sustain the gains that PEFA has already established in the country, to make sure that people on treatment do not drop out of treatment? I think those are the kind of broad lines of discussion that we had. that it is possible that after all, the challenges will be huge. But if the funding is discontinued, I think the member states, Africa CDC has to work with the member states there to fund other alternatives through all this to be able to continue some of this program, because they are really life-saving, especially you cannot cut somebody who's on antiretrovirals and then get that person out of treatment. It is a death sentence. Now, on Nkechi's question about the implication of this decision, as I was saying, the decision just came yesterday. And it came yesterday, and we're in a meeting when somebody just sent that to us. I think it is really something that is not good news at all. Now we have an entire department, I think, at in Africa CDC. We have the Center for Public Health, and there's a division of vaccination. Now that division will work with our health economics team in Addis to then understand also what are the implications, both financially but also on the system, and how is that going to affect vaccination, and then come up with what are the alternative solutions. Just to say that the team is going to work on that. It is really premature, to be honest, for something that came yesterday for us to come already today with a position on that. But we take it at heart, and the team in Addis will be working on that. Just to also inform you that where we see this going is that we have a joint UNICEF and Africa CDC team that is already working on the implications of the US freeze on public health in Africa. As you know, for UNICEF, vaccination is one of their big programs as well. Now, this is really natural that this decision will also fit into the same team, for them also to include that component. And I hope during our next press conference, once they complete, we should be able to come back to you now and say, okay, this is the outcome of the analysis. This is what we see as the way forward from the perspective of Africa CDC.
Thank you, Dr. Ngashi. Let's take the last question. We have Lucia from Spain International News Agency. She has two questions. The first one is about the testing coverage for Mpox. You have told us that the testing coverage for Mpox has increased. Could you clarify and how you define testing coverage? And then the second question is, what are the reasons for this improvement? Several experts have explained that probably emergency responses like the one on Mpox won't be affected long-term by the US aid freeze because money from other projects will be redirected. So I wanted to know and ask what other health sectors will then be hit the most? Those are the questions. Over to you, Dr. Ngashi.
Okay. Yeah, thank you very much. I think testing coverage is defined as the proportion of Mpox cases that are notified, that have been tested to establish whether they have Mpox or not. That's what we call testing coverage. It's just those tested of all the cases that are reported. Now, when we say that 30% in the DRC, but good news to say that in all the other countries is 100% almost. I think with the exception of Burundi, that is around 93%, but all of them are 100%. That every case that meets the case definition of Mpox based on fever, based on skin lesions, is tested to confirm what disease they are suffering from. But in DRC, for now, it's only 1 out of 3. That's what we are defining as testing coverage. Now, it is going up from 13 to 30%. I think one of the things that has happened is first of all, it dropped because of the freeze of the US funding through USAID. As you know, that in DRC, USAID has committed at least $10 million right from the start to support them. That really made a big impact. Now, that freeze had an impact because they also stopped the sample transportation that saw the decline in testing. But at the same time, when this happened, there was also the decentralization of laboratory that was now establishing laboratories in the most affected health zones, With that also is the reduction in the need for sample transportation from the provinces to Kinshasa or from the provinces to Goma. I think it is the effect of that decentralization that is now starting to reverse. But in the DRC plan that Africa CDC and WHO are supporting, the aim is to ensure that in all the 56 hotspot health zones, I think there's a local laboratory that can perform Mpox testing right there. If that works, then we'll overcome this lack of funding for sample transportation. And there was another question, Margaret. What is it?
Yes. So the other question was on the health emergency responses, like the one on Mpox. She has been told that won't be affected by the long-term US aid freeze because the money has been moved. Money will be moved from other projects and redirected for Mpox coverage. So she wanted to know what health sectors will then be hit the most by the aid freeze. That's the question.
The aid freeze, if you look at the US was funding HIV, malaria, maternal and child health, and community health. I think those are the key programs, especially maternal and child health is the program that is going to be most hit. And the second is HIV and malaria. Those are the programs that will suffer most. Now, on emergencies, I think we have to recognize that, especially Mpox, they did contribute a lot. The support was in the area of surveillance, as you know, and then laboratory testing and health workforce. I think those are the areas. Now, the only compensation or the alternative that we have is the pandemic fund. As you know, that pandemic fund had allocated 129 million, also supporting many of these countries in those three areas, so surveillance, laboratory, and health workforce. And you got an update last time from Priya, who reported during the IMST partner meeting that they have already started dispersing the money, and they are concerned about the slow absorption at the end. That's why we are now working with countries to accelerate the absorption to be able to fill the gap, at least for the emergency response. But then what happens for those other programs will be part of the effort that we need to do now at the end of the assessment, is that there will be some reprioritization, and also trying to look at how to adjust the ambitions of all those programs with available resources, but also push to generate more alternative sources through the three that I just mentioned before.
Thank you very much, Dr. Ngashi. And with that, we have come to the end of the weekly briefing this week. I'll now hand it over to you for your closing remarks. Over to you.
Yes, thank you very much, first of all, for your attention. I think it's always a great pleasure to have you on a weekly basis to give you an update. It motivated the team. We really feel accountable to you, that we have to come back and just report to you what we are doing. But most importantly, also is an opportunity for us to share with you some of the challenges that we are facing, so that as you are out there, you can also be our advocate, our champion, to really take the voice out there, to mobilize more in support of the effort we are making on the continent to address these emergencies. I've said that the situation is not yet under control. We are still on the upward trend as we presented the data. But at the same time, we have now a plan. I think this plan has been a result of the co-creation with many of the organizations and the member states themselves. Our main challenge will be now really the resources, both the funding and also the vaccines that we need. Really, we count on all of you to take the voice out there so that we can mobilize as much as possible to get that support. But at the same time, we are also aware of your interest really to know more about the impact of the current health financing development on the African continent. We'll also continue with the assessment. Once we have the result of the assessment, we come back to you and just keep you updated also, not only on the magnitude of the situation, but also on how we are planning to address that. even the most recent one, of Gavi, is too early, but I think the teams will be working together. I hope that by next week, we should be able to give you some preliminary indication of what we see, the possible impact, and also if there are any alternative solution. I think thank you very much. I think we look forward to seeing you again next week, same day, at the same time.